All right, so I'm going to introduce myself quickly. My name is Damilola Jolayemi, and I am a program coordinator with the Center for Behavioral and Addiction Medicine at UCLA. This is a case-based learning collaborative on stimulants. It's a bi-weekly series, and we offer CME credits. This is hosted, obviously, by CBAM, which is the Center for Behavioral and Addiction Medicine in the Department of Family Medicine at UCLA. So our series are on the first and third Fridays at 12 p.m. to 1 p.m. Pacific time. These are the objectives. I know you've seen this so many times in all of the emails that have gone out, so I would not repeat this again, but just a few housekeeping items. We ask that you use the Q&A for questions, and you can use the chat for your comments during the lecture. Feel free to introduce yourself, say who you are, where you're calling in from, your affiliation in the chat so that we know who is in the room. For folks who are requesting CME credits, please ensure to be here for the entire lecture and complete the evaluation at the end. For closed captioning, that's enabled for this meeting, so you can go ahead and enable that on your particular computer so you can see the transcript. Past presentations are available on the CBAM site, and our next lecture is December 1st at 2023. That will be the last one for this year before we start again in 2024. So I want to welcome you all again to our series today, to our session today, and I will go ahead and invite Dr. Shapta, who is the director at CBAM, to introduce our speaker today.
Thanks, Dottie, and thanks everyone for joining us for an amazing hour today to talk about stimulant use treatment and using a case-based approach. For those of you who don't know Brian, and there's probably not too many, but Dr. Hurley is an addiction physician and the medical director of the Bureau of Substance Abuse Prevention and Control in Los Angeles County Department of Public Health. He's the president of the American Society of Addiction Medicine. That's important because right now they just released a clinical guideline for treating stimulant use disorder, and Brian had a major part in bringing that to fruition. Congratulations. And the co-clinical director of the Addiction Treatment Starts Here program through the Center for Clinical Innovation, focused on the increasing the delivery of medications for addiction treatment in California's community health centers. He's a senior researcher at Friends Institute. He's got many grants that he's led over time, but one of his greatest impacts, and the one that I'm most proud about you, Brian, is your impact on health for people who use stimulants here in LA County. I'm very proud of your work, and I'm proud to be your friend. So I'm really happy to have you here today, and I'm looking forward to learning with you.
Thank you, Steve, and thank you, everybody, for being here. Is my PowerPoint showing up okay?
Yes.
All right. So you will get a copy of these slides. I have a link. It's on my Google Drive. So I will share that in the link probably at some point during the case discussion. I probably have more than 20 minutes worth of didactic content, but I will not exceed 20 minutes in terms of the time, which means there will be details in the slide you can refer back to because it's hundreds and hundreds of page stimulant use disorder guideline that ASAM recently published. And I promise you, we will not cover it all in 20 minutes. In terms of financial disclosures, I am not going to try to sell you anything today. So I don't work for any device manufacturers or drug makers. That being said, I will be talking about medications that are FDA approved, but there's no FDA approved medications for stimulant use disorder. So the medications that I'm talking about, I will be talking about off-label uses. I am the president of ASAM, and ASAM has National Practice Guidelines and courses and conferences, and I will probably end up promoting those at the end. So just it's not I don't make money off of that, but it is sort of a conflict of interest in the sense that I do have this role, and I will probably be talking about ways you can spend money on ASAM products, just so you know. So just I don't want you to feel that with that out of the gate. So for those that haven't read it yet, ASAM has a clinical practice guideline on the management of stimulant use disorder. And it doesn't just talk about what is the counseling and the meds that you use for people with stimulant use disorder. It actually references things like evidence-based prevention. So how do you support, there's a whole part of how do you prevent structural violence and poverty, that the guideline, it was out of scope for the guideline, but it's an important sort of part of this. And then it also talks about harm reduction strategies. because there's a lot of people who use stimulants who are not interested in sort of abstinence-based treatment or the way abstinence-based treatment is historically delivered. So the guideline also talks about harm reduction. And then there is, what are the evidence-based strategies to treat people that use substances? And I did get a chance to go to Barcelona this year, visit their public health, and they have safer consumption site, or sometimes called overdose prevention sites, integrated into their treatment settings. And so a lot of the conversations around like, well, are you talking about this or that? I think the guideline fits into what I will call a comprehensive public health strategy that talks about prevention, harm reduction, treatment, surveillance. Like it's sort of all part of one comprehensive public health driven approach, as opposed to carceral driven approach to people who use drugs. And just to make what I think is evident to many in this group, the people who access harm reduction services oftentimes become the people that access treatment services, but not always at the same time. So the reason that we talk about working with people to use drugs even before they're ready for abstinence is the alternative is people using drugs sort of disconnected from services. And we are in the worst overdose crisis in American history and Los Angeles history. So we cannot just wait until people become spontaneously ready for treatment. Too many people will be dead in that case. So there's a big push towards what are the things that we can do sort of early on in people's substance use kind of trajectory to help support health and wellness. I'm sorry that these slides are so complicated. So let me pivot to a slide that I think is more straightforward, which is what are the things that we have to help people with stimulant use disorder? Meds, counseling, and support. What are the things that we use for depression? Meds, counseling, support. What are the things that we use for diabetes? Meds, diet, exercise. Behavioral medicine is not different for addiction as it is for other medical conditions or other behavioral health conditions. The reason that addiction is oftentimes conceptualized separately has everything to do with stigma and nothing to do with science. Like we conceptualize it differently, mostly out of how like funding and systems are organized, not because there's anything actually fundamentally different about substance use and substance use disorders in terms of the tools that we have available. So I sometimes get asked like, what are the things that I can do in primary care to help my patients with stimulant use disorder? And I've listed them, and after I submitted the slide, I realized actually I should probably just reverse the order. The most important thing you can do with a patient who uses stimulants is develop a therapeutic alliance. Keep the patient coming back. So if nothing else, if you're not prescribing any particular medications, you're not doing any behavioral strategies, therapeutic alliance is fundamental. Have you engaged somebody in such a way where they're going to keep coming back? So what's one thing you could do? Frequent visits, just to like help support the people coming back. Now, what are ways that you can support that? Contingency management, which I will talk a lot about today, is literally you give somebody an incentive for when they come in and exhibit a desired behavior. So classic contingency management, the desired behavior, is your toxicology verified abstinence of stimulants, right? And so that could be a good reason why somebody might come back. But if somebody's not interested in abstinence, they're not going to participate in an abstinence-focused CM program. That's okay. Like, what are the other things that the person gets out of visit? I would say like frequent visits, like keep the person coming back, because that becomes the foundation for anything else that you can do. There's also medication management, which most primary care settings deliver to patients, right? Meds. And then behavioral health visits. So skills, strategies, counseling. Primary care clinicians can actually do, oftentimes a brief intervention is a well-codified brief counseling style, and there's more structured types of counseling. When working with people who use stimulants, step one, are they overdosing? Right? Is there any acute medical conditions, are they having an active cardiac event? Okay, the practice guideline that ASAM put together actually has a lot on acute care hospital management. So for those of you that are like hospitalists, intensivists, like working in acute care, there's a lot in the guideline for you. I will not cover all of it today. And then, assuming somebody does not need to go directly to emergency room, what are the risky patterns of stimulant use? What are the routes of administration? Are there any risky behaviors including injection behaviors or sexual behaviors, both of which would qualify people for PrEP or PEP. Are there any co-occurring medical or psychiatric conditions? I cannot tell you how many people I have met with, quote, the diagnosis of schizophrenia, end quote, that only seem to happen when they use meth, right? This sort of like meth-caused schizophrenia, which is actually diagnostically substance-induced psychotic disorder, not schizophrenia. But we have a system where mental health will see you if you have schizophrenia. Mental health generally does not offer a lot of resources. So this has to do with sort of resource gatekeeping in the diagnosis we use. Anyways, and then making sure for people that are going to continue to use stimulants that harm reduction services are an explicit component of that. What's not in the guideline, or not is clearly defined in the guideline, is as someone who helped write it, how do I put this? The stuff that I feel like CSAM did really well is actually defined a whole series of like, what are the health maintenance things you can do? So the guidelines do talk about things like testing and vaccinations. CSAM spelled this out more specifically. In the guideline, the writing committee basically said, refer to the CDC. You know what I mean? Like refer to national like existing guidance. But things like infectious disease screening, offering PrEP or PEP, vaccinations, screening for depression, anxiety, and psychosis, screening for cognitive deficits. There's a whole set of systems that are impacted by stimulants use. So a review of systems can actually yield a lot of useful information around conditions that are responsive to primary care treatment. Don't be aware that there are actually drug interactions, particularly with cytochrome P450 and 3A4, medications that are inhibitors of those cytochrome P450 enzymes can actually increase amphetamine levels. Antacids, for example, decrease the excretion of amphetamine, and there is a risk of concurrent use of things like sildenafil or other phosphodiesterase inhibitors that can increase cardiovascular complications. So just some basic, like, how do you talk with somebody who's not going to stop using stimulants? How might you go? Setting a time limit. Like, have you thought about taking a break to reset your tolerance? Understand that methamphetamine can have a very long duration of action. So, you know, what are your plans for that, right? So you're not saying don't use drugs, which is oftentimes a very common layperson reaction. Oh, use methamphetamine. You shouldn't do that. Telling people to not use drugs has no impact on whether they use drugs. But telling people these are the things that you can consider when you use drugs hits really differently, right? That is a very different conversation because you're not judging or telling them or directing them. You're simply providing counseling and information that they can use. And it feels that even it's a subtle difference, but it's a hugely important difference with how we talk with people to use drugs. If you have a behavioral health department, there are other more structured things you can do, but you do not have to have behavioral health clinicians in your clinic to do things like motivational interviewing, which is structuring a conversation where the person you're talking to, the ideas and values for change come from them. That is motivational interviewing. Now, there's a bunch of skills and strategies and other elements to it. You don't need that. For contingency management, oftentimes you do need at least some staff. I will call it a contingency management manager that evaluates the desired behavior and then delivers the incentive. And actually, Medi-Cal now has a contingency management program. It's limited to non-residential state licensed SUD or state certified SUD facility. So it's not in primary care, at least not yet, but can be operationalized in a whole number of settings. And then there are more intensive things like community reinforcement approach, cognitive behavioral therapy, which can be comfortably delivered in a clinic, the matrix model, which is something that you would typically go to a specialty center to get. But I'm going to spend most of my time on CM because it is absolutely by far the most impactful treatment that we have in terms of just efficacy. Like what is the effect size for people that receive contingency management? So the basic assumption is that substance use can be reduced using operant conditioning. It promotes treatment adherence, and the most common style of contingency management is to provide somebody an incentive if they test negative for a desired category. So in California's case, we run a Medi-Cal funded contingency management program where people that test negative for stimulants, that's amphetamines, methamphetamine, and cocaine, get an incentive. Up to $600 a year. It's a non-trivial one. I mean, cumulatively, not all at once, but you know, like It starts off at like $12.50, and then you get escalating amounts over time. The assumption is that the behavior has to be modifiable, like the person did or didn't use stimulant. There's other things you could focus on, like medication adherence. The person did or didn't take their medication, or the patient did or didn't show up to an appointment. But either way, like it has to be it can't be like I felt better. It can't be like it can't be. It has to be like a modifiable behavior that is objectively monitored, right? Like binary yes or no, did you or didn't you? For contingency management to really work, you have to have immediate reinforcement. So one errors I've sort of seen with CM programs is they send urine to a lab, 3 days later it comes back, then the person gets their incentive. That is way too much time between the measurement of the behavior and the incentive. And then there's oftentimes a withholding of the incentive if the behavior is unsuccessful. And this is actually oftentimes why having a CM coordinator that is not involved in the clinical care of the patient, by which I mean they're not also doing counseling, they're literally just doing CM, can be helpful, because most counselors are rooting for the patient. So the patient's like, I swear, I only use once this week. I'm so much better. You're rooting for them. So you're like, oh yeah, you like want to give them the incentive. And actually that decreases the effectiveness of contingency management, because it has to be, it's sort of on the basis of what is objectively measured. It doesn't just have to be urine testing. So counseling attendance, if any of you have had a patient in an opiate treatment program, they get more take-home doses the longer they're doing well, right? That is actually contingency management, right? It's a type of contingency management. And contingency management, if I mentioned $600 or $599, can get expensive, particularly if you do it at scale. So how do you do this more affordably? So Nancy Petrie, and thank you, Steve, for connecting me to Nancy directly. Nancy is actually passed away in 2018, but I got a chance to work with her because of Steve. So thank you, Steve. I published a lot about something called the fishbowl method. So the fishbowl method is there's a bunch of slips of paper in a fishbowl, and the incentive is not the incentive, it's the draw. Like, in other words, like the incentive is how many draws you get from the fishbowl. And then, so for each, say, stimulant negative urine, you could, like the first week you get 1 draw, the second week you get 2 draws, you can sort of do this escalating number of draws. Now, you have to have a reasonable number of winning slips, but if you think about it, like half the slips are good job, just an affirmation. The other half of the slips are like largest chance of a $1 prize, and then like there's a handful of slips that have a $20 prize, and like one slip that's $100, like you have this escalating incentive. For those of you that ever have patients that use scratchers, it's the exact same idea. Most scratch tickets like have this like, a lot of them are worth a very like nothing or very little amounts of money. It's the same sort of like, that's the same sort of prompt is draws from the bowl or the actual incentive. And how well does this work? This has been published since the 90s. Much better than standard treatment. Right? So the white dots are the behavioral treatment, which is this is the contingency management, versus standard treatment, which is the blue dots. This was a cocaine study, but we see the same evidence with methamphetamine use disorder, which is contingency management is from ASAM's perspective, a standard of care for people with stimulant use disorder. So what is the language we use? CM has demonstrated the best effectiveness in the treatment of stimulant use disorder compared to any other intervention study, and is the standard of care, and can be combined with anything. It can be combined with cognitive behavioral therapy, doing your first one approach, medication treatments. You can combine it with anything. All right, and I mentioned anyone can do motivational interviewing. You evoke change talk from individuals. You structure the conversation that way. Here are some of the strategies, and conflict of interest alert. I teach ASAM's motivational interviewing course. You are welcome to sign up for it. I would love to like, it's like a 6-hour thing. And anyway, would love to continue that conversation. There's cognitive behavioral therapy that focuses on thoughts, emotions, and behaviors. We could do an entire hour on CBT. In fact, we can do an entire like semester on CBT. Suffice it to say, CBT has an evidence basis to helping people to use stimulants, use less, or even stop. And then the community reinforcement approach is built around a function analysis of substance use, counseling, vocational guidance and skills, drug refusal skills, and setting up new non-use activities in people's lives. This oftentimes requires a behavioral team. It's not like one person doing all of this, but there's like a behavioral team doing this. And then there's the like formal structured matrix model, which is intensive outpatient, which is what IOP stands for. It is intensive outpatient curriculum that goes through an entire set of groups that's built on CBT and other reinforcements. So in my 5 minutes, maybe, that I have left of the didactic before we get to the cases. So let's just talk briefly about the medications for stimulant use disorder. There are non-psychostimulant medications that are not scheduled medications. And then there are actually psychostimulant medications that show effectiveness at reducing stimulant use. The psychostimulant medications are not terribly, none of these medications are hugely effective, by which I mean you see this like big effect size and reduction in stimulant use, but you do see a change, right? It is a change, a reduction in stimulant use. It's not huge, but it's meaningful. And I will tell you, for those of you that have patients that take antihypertensives, you know what I mean about blood pressure may not be perfect, but it's lower than it was, last time. Like we see that all the time. So this is, I would say, on par with a lot of other treatments that we do in primary care. But nonetheless, just as a caveat, although we mentioned psychostimulants, unless you're a board certified addiction physician or somebody like training with or with a lot of experience, I would not default to prescribing psychostimulants to patients with stimulant use disorder. Like there is an entire framework around like monitoring and that's a high risk treatment. I would only do that when an addiction physician is involved, and that is actually in the guideline. Psychostimulant medication. So I'm going to focus mostly on the non-stimulants, even though the guideline talks about all of it. I just wanted to separate that out. So the non-psychostimulant medications for methamphetamine use disorder, the combination of naltrexone extended release injection plus 450 extended release bupropion, right? Like high dose or max dose bupropion. Mirtazapine has 2 small studies. Bupropion on its own has 2 small studies. Topiramate also seems to help. Mostly it signals in people that don't use methamphetamine very much. And the guideline also says, although there is we didn't see enough evidence of oral naltrexone, there's no reason to assume that oral naltrexone that someone's adherent to would necessarily be different. You know what I mean? It's just there's no real evidence for that. So if somebody's adherent to oral naltrexone, like could you use it? You could. It just the person just needs to take it regularly. But the actual study, the evidence in responses for naltrexone extended release injection, and then in terms of psychostimulants, it's methylphenidate. For cocaine, we have bupropion, topiramate, and modafinil. And then in the psychostimulant realm, the combination of mixed amphetamine salts and topiramate, and then mixed amphetamine salts extended release on its own. And I am ultimately going to defer a lot of the like charts and dosing strategies it's in the slide deck, but it would take another half hour, and it's totally look upable what are the actual med like dosing and strategies. But I will say we didn't see enough evidence for text messaging or brain stimulation alone, exercise as standalone treatment, auricular acupuncture as a standalone treatment. And then we looked at oral naltrexone and oral naltrexone with N-acetylcysteine, did not see enough evidence to remark on those individually. So I have prepared 3 cases, but before we jump into my cases, are there any questions anyone has? And if there's any cases any of you have that you're like, oh my goodness, there's this like case I really want to run by the group, I actually would love to hear from you first before we jump into like my prep stuff.
So Brian, there is a question from Heather Brostrand. Heather, do you want to unmute and ask your question, or do you want me to just go ahead?
Well, thank you so much. Thank you so much. I don't know question, but I do QI, and we've got some rules and regs that specifically prohibit us from talking about use of illegal drugs, which really ties our hands with harm reduction. And of course, UCLA would be a great advocate for getting those regulations changed. Any suggestion? I mean, I can't talk about using less cocaine.
What reg says you can't talk with somebody about using less cocaine?
Oh, you were not allowed to speak about illegal drug use. I can look it up for you.
Yeah, that'd be helpful.
Sure.
I suspect that I am familiar with Title IX and a lot of the licensing regs that impact SUD programs, but I don't know for FQHCs or other community health centers if that's true. And I'll tell you, our bureau here at LA County is very vocal with the state about advocating for regulatory improvements that create more flexibility for providers. Assuming nothing changes in the regs, one thing that I do in terms of motivational interviewing is structure the conversation where the patient is talking about it. So I might still be permitted to hear what somebody's goals and ideas and intentions are, even if I'm not the one sort of making statements that might put me at risk. Does that make sense? But yes, Heather, we'd love to hear more around the regs that are tying your hands, because if we can untie them, that would be really important. So Joanna says, it'd be helpful if there was a focus on societal issues, trauma, poverty, domestic violence to help decrease the chance of people using substances in the first place. I mean, preach. Yeah, absolutely. Like if we didn't have whole communities disproportionately impacted by concentrated poverty, violence, disenfranchisement, under-resourcing, like that would make racism, right? Homophobia, transphobia, violence, right? I mean, there are so many social drivers of substance use that I like sorry to keep going back to it, but I really did like the way the Spanish talked about this. Like how do we help people have healthy lives where they can develop and, maximize their own like health and wellness and achievement, not impacted by all of the adverse childhood events and all of the, like, there's a lot in terms of positive youth development and then substance use prevention that speaks to the social determinants of health. So yes, I agree with all of that. I will also say the Stimulant Use Disorder National Practice Guideline is not a housing poverty, like we mentioned trauma-informed care, we mentioned navigation and housing resources, but it's not focused on those things because that would be like a much broader scope document. And what about the stuff they're putting in meth that cause other effects? So Richard, I presume you're talking about things like high potency synthetic opioids such as fentanyl, which can then also be mixed with things like xylazine, which is like alpha-2 agonist that has tranquilizing effects. Yeah, totally. So what is the stuff that you do for a patient who could be exposed to fentanyl inconsistently, right? So they don't have a fentanyl tolerance. So universal access to naloxone, right? Like everybody with a substance use disorder should have access to naloxone. It doesn't matter whether it's an opioid use disorder, stimulant use disorder, sedative use disorder, like just universal access to naloxone as a standard of care. So that way, if somebody overdoses, and then fentanyl test strips, anticipatory guidance. As I'm sitting here talking to you, I can't remember how detailed ASAM was in putting all of those specific details, but that's stuff I put it. Forgive that I didn't highlight that in here as directly as I typically do, but we yes, naloxone, test strips, anticipatory guidance. Make sure people know where in the community they can get their drugs tested. LA County contracts with a series of harm reduction and service programs that UCLA partners with us on drug testing with. So thank you to UCLA. And we recently got a CDC grant to expand that. So those are all things that for LA County residents, you can help support your patients accessing those types of services. Natasha says, I had a patient who used cocaine and had type 1 diabetes who was not accepted to most treatments. Seems like CM would have been good. Where can these patients go? All right. I was going to cover this later. There is actually a 24/7 phone number that anyone in any Medi-Cal beneficiary in LA County can call to get access to non-residential STD programs, including programs that offer CM. And I will put a link to the LA County contingency management programs where you can refer patients. There's also a website, but the website that lists non-residential programs does not actually list CM. There's another list for that. Long story, but I'll send you both so that you can find it. And then there is a whole bunch of stuff on the Recover LA mobile app. So if you have your phone and you want to look at the QR code, you can. Mark says, for CM, do I prefer fishbowl or increasing values of incentives? So the nice thing about the increasing value of incentives is there's no ambiguity from the patient. The fishbowl seems to be comparably effective, and it's much cheaper. So it depends on which perspective you're looking at. If cost was no object, well, fixed benefit incentives have a very reliable response. Fishbowl does too, and is a much more cost-saving incentive. So in the balance of cost, you're probably gonna do fishbowl. If the feds are paying for it through Medi-Cal, then the state of California picked the fixed incentive. How has inflation affected the value of contingencies? Yeah, you need to make sure that the amounts that you're giving are clinically meaningful. So, you know, $15 an incentive up to $75 a year is not going to be enough. Like, you have to use clinically appropriate amounts in order for patients to benefit. And it's going to change, right, as inflation goes up over time. Oh, have I ever paired desired behaviors like negative urine and regular monitoring of A1C? You certainly can, right? Like that would, I don't know, I'm unaware of any research on like A1C levels, because A1C is usually something you get, and I'm not a primary care doctor, so I'm putting myself on a limb here, quarterly, maybe, you know what I mean? It's not something you're necessarily doing each time, but you could, particularly if you're looking for, it just, A1C, as I recall, sort of is a sum of blood glucose or serum glucose over time. So you're not necessarily going to see a change like like twice a week, the way you would with substance use. I'm feeling some pressure to get to the cases. Any other cases anyone wants to bring up? Jessica, do you feel comfortable reading this one?
Yeah, sure. So case number 1, we have a 23-year-old cisgender man using methamphetamine, nicotine, and cannabis. Mr. Brown is a 23-year-old HIV negative male, smokes methamphetamine in 2 to 3 day binges 2 to 4 times a month, and his methamphetamine use is typically concurrent with group sexual activity, and he is sexually active with both men and women. He is prescribed PrEP, which is a prophylaxis for HIV, which he takes consistently. He reports no history of chronic medical conditions or taking non-PrEP medications. During his methamphetamine binge episodes, he typically does not sleep. After these episodes, he sleeps for over 24 hours and feels depressive symptoms, including deflated self-attitude. He vapes 5 milligrams of nicotine daily, a 20 milligram pod lasts 4 days, and smokes cannabis daily. He denies consuming alcohol, using opioids, and denies any other substance use. He's not ready to stop using methamphetamine, vaping, or using cannabis.
What other information would people want to know about this case?
Right off the bat, I'd like to know a little bit more about his social situation. Is he working? Is he living in a home? Or what does that look like?
Yeah. If he was, let's say, living in an unsheltered setting, you know, maybe without currently not enrolled. I mean, he's getting PrEP, so somehow, but maybe he's getting from a Ryan White clinic as opposed to he may not be enrolled in Medi-Cal, right? So like, what's his insurance status, living situation? That would be really helpful. Versus, is he employed, housed, and you know, is he commercially insured, right? That may impact what we might do. Heather? And Heather, if you're speaking, you're muted.
What about other medical conditions? Because I mean, he's getting PrEP for HIV, but has he been screened for chlamydia for any other STIs?
Yeah. So that would be one question is, although he says I don't have any chronic medical conditions, what is his screening for other infections? Yeah, that's fair. Sorry, Heather, was it, go ahead, what were you gonna say? Heather, I think you're muted, but feel free to chime in. Any other, let me check the chat. Yeah, any mental health, employed, or is he interested in decreasing use? Yeah, it'd be useful to know if he's not ready to stop, but is he interested in decreasing use? Is he interested in reducing the meth, but not the nicotine or cannabis? So maybe take those 3 separately. Yep. Any other, what does the support system look like?
I would also want to know like why he likes to use meth. Like, what is he getting out of it? And what if he has any like perceived like disadvantages or consequences of using meth besides feeling bad the next day?
Yeah. What is he getting out of it? So we know that after a meth binge, he hasn't slept and sleeps a lot, and he has a deflated self-attitude. But what does he get during it would be really helpful to know. Yeah, how long has he been using, and is there a family history of STDs? Those are great questions, Sarah.
I guess some other question would be how the meth is actually impacting his daily life, work, family, finances, social, all of that.
Yeah. Is it having any like functional impact, right? And is he experiencing any trauma, right? Or does he have any trauma history? And are they preventing him from working regularly? So let me, this is clearly a made up case, so I'm going to make some additional stuff up to help guide our conversation. So he is housed with family that don't know anything about his sexual activity. He does work odd jobs, so he has some income, but he notices when during the meth binges and in the days following, he like does not show up to stuff. So that's why he's not able to keep a regular job, is because like there are times when he just like doesn't feel up for going. So he can sort of sustain odd jobs now and again, but he's not necessarily regularly employed. He doesn't report a trauma history, but again, it often takes time working with somebody in order to learn that information. He has unprotected sex at these group sexual events that he attends. That's why he takes PrEP. He sort of cares about his health and wellness. He sometimes goes in for testing. He has not gone in for testing for other infections recently. He doesn't feel like the situations are particularly unsafe. So let's see, no trauma history, no other particular medical conditions that he reports, and oh gosh, I'm sure no other particular mental health features. You know, his kind of like deflated self-attitude goes away within a few days of of the meth binge. And what he likes, Matt, to your point, what does he like about it? It gives him a lot of energy. He feels really sexy, right? He feels really like it gives him a lot of like boost and energy and motivation, and he feels like he's able to really, release when he's using methamphetamine. Heather, he smokes and does not inject. What did I miss? I'm just making this up as I go, but that was my best shot to kind of go through the list of things. And so maybe we could talk a little bit more about management. What are the things that we might offer? Jessica, any thoughts about what we might offer Mr. Brown?
Yes, I am distracted trying to figure out who is unmuted. I think right off the bat, if there is a program for CM like that he is eligible for, that might be a good thing for him. There might also be other connections too. I know a lot of these CM places will also offer regular HIV testing, since he does seem to care and does want to know. So that could be something there as well. The other thing I'm also thinking about is medications, obviously, and it sounds like he's a generally blank slate, doesn't have a whole lot of other things I need to worry about when it comes to prescribing some of these antidepressants or other medications. So those are my first two thoughts. So
those are all excellent thoughts, right? Med CM, like those should be always top of mind whenever we're working with a patient with a stimulant use disorder. I agree with all of that. I think testing would be helpful. You know what I mean? Like he is on PrEP, and so he's getting quarterly HIV testing. He should probably be at least getting quarterly other sexually transmitted infection screening that accord with the ways he has sex, right? So throat, butt, urine, you know what I mean? Like depending on his actual like sexual behavior. And then CM, it depends on the CM program, right? Because if he's not going to stop using methamphetamine, he's never going to get an incentive. So I think it depends on, like, you could talk to him about CM and gauge his readiness. If he says, no, I'm going to keep using, like, I'm not going to stop using. But one thing you could do is to say, okay, have you thought about maybe sleeping during these binges. You know what I mean? Like rather than a binge going for X number of days, you thought maybe like shortening the binge and sleeping. Would mirtazapine, which can help you sleep, be helpful, right? That might push me towards mirtazapine. He's not smoking he is using nicotine. That also brings up bupropion. And so that also is like, well, should we try bupropion plus naltrexone? Could be another option, which can reduce methamphetamine use, right? So I would be thinking like meds, is there any particular med strategy that he would be on board with? And testing, and then I'll just call it some like harm reduction guidance around, hey, have you thought about, taking breaks from stimulant use for longer? Are you interested in anything for sleep? Like that's how I would be thinking about it. I do have another case, but before we jump in, are there any other comments, any other thoughts that anyone has? And Natasha says, is he comfortable with sleeping with men and women, or these covert escapades? Yeah, that's a great question, right? Like what processing around his sexual behavior or sexual orientation, right, is relevant to him? I think would be a great question. I think I interrupted somebody.
Hey, yeah. So I guess in this case, also for this patient, we're offering PrEP and we're thinking about medication, but this is also like that we can do in clinic, not necessarily being a physician. We can provide condoms because, I mean, preventing HIV infection, right? But what about other STIs?
Totally.
So this is something that we can implement in all stages, from clinic to hospital. So that's something that we can start to.
Totally. Thanks, Giovanni.
And then Dr. Hurley, I do have a question. I think just in general, maybe not necessarily related to this case particular, but say this man did have a history of like bipolar or schizoaffective, something where you're a little bit more worried. Like that gives me a little bit more pause if I were to just start Wellbutrin on this person.
Totally.
Do you have thoughts on like, how can we be more safe, or how can we be more rest assured that maybe we won't induce someone to go into mania if it is indeed a concern with someone who has in the past?
Oh, goodness, that's such a good question. Okay, so I suggest there's a two-step process. The first step is, let's say there's somebody that has, and I'm going to repeat a term to you that I've heard before. The term is the bipolar, right? I have the bipolar. Okay, so one question is, do you actually have bipolar disorder? So have you been psychiatrically hospitalized? If not, doesn't mean you don't have bipolar, but it means that whatever your bipolar is has not been sufficiently out of control such that you've required inpatient psychiatric hospitalization. Also, do you get bipolar when you are not using meth, right? Because methamphetamine induces a lot of activation that can mimic mania, right? Now, those aren't perfect questions, but those are oftentimes, and I'm a psychiatrist, so like those are, so I'm thinking of separating out like, who may have gotten the diagnosis of the bipolar, maybe not cleanly, right? As a way for a mental health clinician to begin to give them access, especially mental health services, but they don't actually have bipolar disorder. But let's say somebody gives me a reliable history of bipolar disorder. Yes, I go through depressive episodes and activated episodes well before I started using drugs ever in my life, multiple psychiatric hospitalizations. Then I default to the second thing, which is, are you on a mood stabilizer? If you are on a mood stabilizer, the risk of converting somebody into mania with an antidepressant is very low. Now, just because you're prescribed a mood stabilizer, I mean, you're on a mood stabilizer. I need to know, are you on it? Like, are you either going through monthly injections or adherent to your oral medication? And in fact, I might add, like, serum lithium or serum valproate, which are two commonly used mood stabilizers, to my next set of lab tests to see, is there evidence, right? I don't mean to withhold antidepressants from anybody, but if somebody has true bipolar disorder and they're on a mood stabilizer, I'd still do it. And not everyone says they have bipolar has bipolar, right? So just like try to do some shifting from the, is this only something that ever started in your life after you started using drugs? And because you'll get histories from people, yeah, I was off of methamphetamine for a year, no mental health meds, no mental health diagnoses, I was doing just fine. I'm like, then I actually don't know that I need to withhold antidepressant treatment from you.
That makes sense. Would you suggest saying we should see the patient stable on the mood stabilizer first? Because I feel like I've been in the situation where I thought of this, I prescribed like the beginning dose of an antipsychotic, But I don't know how long to wait to feel like it's safe then to start something else.
The research is once they're on it. So there's
Once they're on
no
it.
particular once they're on it, right? And this is why frequent visits helps. So let's say you did it wrong. I don't mean to like shame, but let's say you're on 5 of aripiprazole. That's not enough of a mood stabilizer dose. Well, you see them frequently enough, you'll be able to sort of get ahead of that. Do you know what I mean?
Mhm.
So this is why, like, even if you using your best judgment, you did it, you know what I mean? Like maybe somebody began to get really activated. Okay, like, sorry that didn't work. We're going to take you off the antidepressant. You know what I mean? Then we're going to pivot to something else.
Got it. Thank you. That was very helpful.
Yeah, for sure. Because keep in mind, if you think an antidepressant is stimulating, try methamphetamine. like they're already on. You know, like, do you see what I'm saying? Like
Fair.
is the antidepressant really going to be worse than the meth that they're taking for their quote bipolar disorder? Like, you know what I mean? So like I understand the concern, but I'm like, but these like they're well past bupropion in terms of like risk profile. All right. I do want to go through the other case. I know we're running out of time. So do we have more than one fellow, or Jessica, are you?
Gio's on too.
Oh, hey, Gio,
Great.
thanks. Can you do case 2?
Absolutely, yeah. Case number 2 is a 32-year-old cisgender woman using methamphetamine as well. So this is Miss Green. Is a 32-year-old HIV negative cisgender woman who recently became homeless after the end of a relationship. She began using methamphetamine to maintain alertness overnight in the encampment where she has been staying. She was brought in by an ambulance to a local hospital with symptoms of acute agitation. The EMS brought her into the emergency room after she became behaviorally disrupted at her encampment. On interview in the emergency department, she reported feeling as though everyone in her encampment was plotting against her and began feeling the sensation of insects crawling underneath her skin. She usually experiences these symptoms when she uses methamphetamines, but they resolve within a day of stopping methamphetamine use. Urine labs obtained in the emergency room were positive for amphetamines and positive for human chorionic gonadotrophin or beta-ACG pregnancy test.
What else do we want to know about Ms. Green?
Is she using any other substances other than methamphetamines?
Excellent question.
Alcohol, opioids, we name it.
Nicotine. We always forget about that one, but
Yeah,
she's using nicotine. Yeah.
Has she ever seen a doctor before? Has she ever had like a physical check?
Is she taking any medications? Does she have any medical problems? Yeah.
Exactly.
Like maybe get an H&P.
Yep.
Lincoln brings up, what is the remaining support? What does her support system look like? If there's history. And then Mark brings up, is there a history of HIV, especially since now that she's pregnant, or does she even realize she's pregnant?
Yeah, it's a great question. Does she know she's pregnant? Was she tested for HIV at the hospital, in which case we know she's HIV negative, or is this by her history, right? So what, like, to what extent is that confirmed? Sorry, the psychiatrist in me cannot resist. What is the name for when you feel like the sensation of insects crawling under your skin? Does anyone know? Formication, not it's an M, not an N. Formication is the name of that sensation, and it is a psychotic. It's not real, but people do feel like it's a very distinct sensation that seems to come with stimulants. Yeah, David, when's the last time she slept? Does she know she's pregnant? And then what would be her goals for the pregnancy, right? When was her last menstrual period? How far along is she? There's a lot of other questions. Marcia?
Yeah. In AOD world, the language that you used, we wouldn't use because most people wouldn't be able to recognize it. We just call it pick and fleas.
Yeah, that's right. Pick and fleas.
Yeah. My question again is all of the questions that we as substance abuse people use on the California ASAM, the route of administration, family history. Has there been periods where she hadn't been using? What age did she start using? Did she start with methamphetamine, or did she start with something else, and did it evolve into meth use? Is there a history of trauma? We would be going through all of that information in a series of assessments.
A comprehensive ASAM diagnostic assessment. I will also say virtually nobody that I know gets that level of assessment in the emergency room. Usually you have to go to a treatment program for that. You know what I mean? Like that's on arrival to the treatment program. So on one hand, ASAM is a very comprehensive psychosocial assessment. On the other hand, I don't want to leave the impression to anyone here, if you have not done a 90-minute ASAM, that you can't talk to somebody. You know what I mean? Like there's absolutely helpful information you can get even pending, a full ASAM. And then Vanessa says, is for medication happen with meth specifically? Meth and cocaine. I've seen it with both, and it is quite common. Like you said, Marcia, tick and fleas. You know what I mean? Like, yeah. And then Stephen says, homeless following the end of the relationship and possible another pregnancy make you think about abuse and victimization. You'd want to know more around her living situation, her safety. Yeah, absolutely. So I'll make some stuff up, and then we'll jump into management. She does not know she's pregnant. At the ER, they did an HIV test. It is negative. She does not have any family history, and actually just recently started using meth. So she does not use tobacco, does not use alcohol, did not use any other substances, was introduced to meth by somebody in her encampment, right? And part of it was she just didn't feel safe at night. There's like people walking around. So this was just a way for her to sort of, like, she's newly homeless, new to this. This to her was a tool. And then she became kind of psychotic. Then she began to have these tactile hallucinations, began to have this feeling like people are out to get her. She lost behavioral control, but she does not have this like long history of alcohol, cannabis, or substance use. And when you ask her goals for her pregnancy, oh my God, she has no idea. You know what I mean? Like that is well beyond where she has thought through at this point. Like she hasn't decided, is it desired, not desired. She's just learning this for the first time. So what might we do for Ms. Green?
Poor thing. I'm thinking if a lot of these symptoms may have only started with her methamphetamine use, maybe this is just, methamphetamine-induced psychosis, and we should treat it as that, and see if, what her plans are, hopefully she can find housing and somewhere more stable soon where she feels safe, so she doesn't feel the need to go back to using methamphetamines.
So a couple things. One, her pregnancy actually qualifies for a whole number of interim housing resources that she would not have had access to without being pregnant, right? So like, on one hand, the pregnancy is a complicating factor. And on the other hand, there are a whole number of what are called pregnancy and parenting resources that are available in the public sector. So that's one thing. Second thing, do you treat her psychosis with antipsychotics?
I think I've seen people do it if they really think it's substance induced for a short period of time, but like maybe while they're in the hospital, and not send them home with it necessarily.
So there is, sorry, go ahead, Gio.
Yeah, I guess, you have to do like a more comprehensive assessment, because otherwise yes, this could be one of the reasons, but how sure are we that this is related to the substance and not maybe some underlying condition?
So for the sake of this case, let's say you have enough information to say that that's true. Like no other mental health history. This truly does seem to be, she says, I've had this before, but not quite as bad. Now is as bad as it's ever been, but it only happens when I use meth. And it goes away when I stop using meth, which is, not purely diagnostic, but like 32 years old is later to develop like a first break. You can still have it, but it's a sort of a late age to be developing like a first break psychosis. There is an evidence. There's research on using antipsychotics to treat stimulant-induced psychosis, which is positive studies. That is to say, antipsychotics can treat stimulant-induced psychosis. It's kind of like treating Tylenol with a fever. Does Tylenol solve an infection or inflammation or, again, I'm a psychiatrist, I don't know what causes fever, but whatever the cause of fever is, right? Does Tylenol treat that? No. What does it do? Brings down your temperature. That's what it does. So what do antipsychotics do? Make you less psychotic. You give her some relief. The difference between that and somebody with a problematic psychotic disorder is time frame, right? Now, you can give somebody on release from the hospital antipsychotics that they can take as needed, right? It's a very different way of dosing it than you would dose somebody with a chronic psychotic disorder. But I don't want anyone to hear to feel, ooh, I don't have diagnostic purity, I can't do it. You can treat fever with Tylenol. you can treat psychosis with antipsychotics, even if you don't have perfect diagnostic clarity. All right, I think that I am at 4 minutes, and oh yeah, and thank you to all the comments around like linking her to services, housing with healthcare, make sure that we're sort of attending to her safety and victimization. Housing is going to be fundamental to that. It gets her out off the street where she is going to be at a disproportionate risk. I could go on and on. It's good. Thank you for having me. I'm going to turn it back to our organizers to close us out. So thank you very much.
So, Dr. Hurley, that was fantastic. It really just raised the bar for the folks who are coming after you. I mean, this has been a master class in how you do case-based learning. I learned, it was awesome. So, thank you very much. It is always great to have you here. You're always welcome to come back. Let me just put that out for you.
Thank you.
It is wonderful what you're doing. The depth of your experience and your academic expertise here just really comes through. You speak in cases, so that's exactly what we want, because this is what we miss in a lot of our instruction within the UCLA medical school, the fellowships, places like that. I mean, we need more of this case-based learning that pulls together all the literature and things you talked about. So I just want to say hats off. Thanks very much. Happy Thanksgiving. And thanks to everyone for joining us today.
Thank you, everybody. With any questions, send me an email, and then huge conflict of interest. See you in Dallas for ASAM. See you in San Francisco for CSAM. For those that are driving down to San Diego this December, I'll be there for AAAP. It's good to see everybody.
Great. And Dami, you're going to talk with us about retrieving your CME units, right?
So you will get an evaluation at the end. It's going to actually pop up once we leave this Zoom space. So please complete the evaluation. For folks who are requesting CMEs, the CMEs will all be provided at the end of the year once the final session for this year is concluded. So we will process CMEs all at the same time and send for every lecture that we've had in 2023. So thank you, Dr. Hurley. Thank you, Dr. Shouter. Thank you to Dr. Cruz and Wang and all of the attendees and all of you who participated. That's it for me. Have a good one, everyone. Happy Thanksgiving.
Awesome.
I'm going to leave it on just for I see questions are coming in the chat. So sorry, feel free to exit so we can capture whatever questions there are.
And maybe just for the recording, one question was, do you start with naltrexone? Do you start with topiramate? I usually start actually with naltrexone plus bupropion. The evidence is strongest for that. Topiramate, you can do, the evidence is weaker. It's actually kind of a trend towards positivity, but, like very close to the, non-significant line. And just in relation to the last case, you don't give topiramate to anyone who's pregnant or who could be pregnant, right? So oftentimes you have to watch out for contraceptive. Anyway, so maybe hopefully that'll make it onto the recording.
Yes, it will. Thank you for addressing that question. Thanks, everyone. Have a great day.
Take care. Thanks.
Bye.